Jeff Jensen. I'm a professor here at the School of Social Work and Associate Dean for Research in our school. I'm really delighted to introduce Dan Herman this morning, who's going to talk with us about some very exciting intervention research he's been doing with homeless populations. And by way of introduction, Dan's an associate professor of clinical epidemiology in the Department of Psychiatry and located in the Mailman School of Public Health at Columbia University in New York. In addition to his role at the Mailman School, Dan is a research scientist in the New York State Psychiatric Institute, where he also serves as the Director of Research in the Department of Social Work. He's carried out numerous studies involving homeless populations, including randomized trials of critical time intervention, or CTI, which he's, I'm sure, going to talk to us about this morning. This is a psychosocial intervention designed to prevent recurrent homelessness in mentally ill men and women following discharge from psychiatric hospitals and other institutions. And Dan's now very active in moving what he's learned from these intervention trials to a higher level, if you will, of dissemination of the intervention in several mental health systems in the country. Dan's also done epidemiological research on long-term outcomes associated with adverse childhood experiences, has carried out research in New York City on mental health implications of the September 11th attacks. And as you can see from his brief description, he's been a very active researcher in fields of psychiatry and social work, and particularly strong in intervention research, where his work's been funded by the likes of the National Institute of Mental Health, Alliance for Research on Schizophrenia and Affective Disorders. He's also a past president of the Society, vice president of the Society for Social Work and Research. So, with that, let me turn it over to Dan. Welcome, Dan. I'm delighted to have you here today.
Thank you. So you can all hear me okay? Good. All right, so thanks, Jeff. Thanks a lot for that generous introduction. And I also want to thank Dean Williams for inviting me. I understand he's out of the country right now, so I'm sorry I'm not getting to see him. He's an old friend of mine through SWR. And I've also known Jeff for many years through the Society for Social Work and Research. So it's a pleasure for me to be here. I'm going to, let me just, before I go into the formal talk portion of the presentation, I just want to tell you a little bit about my background, just not because I'm so inherently fascinating as a person, but only just so you understand how my work comes out of which is what I'm going to be presenting today is around a particular, is the description of the development of a particular intervention model and some research that we've carried out to test it, but also how that comes out of my experience as a social worker. So I started my career before I had gray hair, which I quickly got being a social worker, working in a bunch of different social service agencies in New York City and mental health agencies, which was around the time of the sort of beginning of the homelessness crisis as it was thought at the time, which now obviously we know is not really a crisis as much as sort of an endemic sort of feature of American society. But, and so my original work as a social worker in these agencies was during that era, and so for a bunch of years I worked in outreach programs and housing programs, and before I think we really had a clear understanding, or as clear an understanding as we do today, of the scope of the problem and the nature of the problem, and also before we really had much sort of careful thinking about some more or less effective intervention strategies. And I did that for a pretty long time, and I worked in the city government, involved with organizing and funding some of these services, and I worked in the state public mental health system in a big psychiatric hospital. And then about 10 or probably 15 years ago now, I kind of made a transition into more research and teaching jobs, also in New York. And so just so this is all by way of saying two things, basically. One, that you can, that I think as a social worker who gets sort of plunged into all the challenges of being a direct service provider, this is a very valuable experience and very important in itself, and you can spend your whole career doing that. And it's a good thing to do. You can also sort of learn from that experience, and some people will think about ways to kind of try to apply and think more systematically about what they're doing, and maybe go on to develop research or interventions and study them. And it's not an easy path to follow, sort of a research career in the field of social work, but it's a very rewarding one also. So to try to look systematically at our practice and what we're doing, and try to sort of spread sort of our experience and knowledge. So anyway, that's just a pitch. I know part of Jeff's job is to help generate research interest and sort of foster and mentor people who are interested in that field, and it's a it's a great thing to do if it's something that's for you. So what I'll do is, and let me just try to keep track of the time. So what I'm going to do is talk about CTI, this model that we've developed, been working on probably over the last 15 plus years, that's focused, as Jeff said, on prevention of recurrent homelessness in people with severe mental illness. And so I'll describe a little bit about the background of the model. I'll describe the model that we've developed, and then a little summarize some of the research that we've been able to carry out that's looked at, and others have been able to carry out that's been able to look at sort of the effectiveness or test the effectiveness of the model. And so I'll try to do all that in about 30 or 35 minutes to leave plenty of time to so we can have some discussion or questions. As I'm going, if I say something that's like really, really unclear, feel free to interrupt me to clarify if you feel the need. That's fine with me too. So let me just get a little drink of water. So oh, good. So the picture you can see well. So this is a photograph of the New York, of a big shelter for homeless people in New York City in the 1990s. So it's a little hard to maybe make out what this is, but it's a huge building, something that was an armory used for storing big weapons, and you can't really get the size of this scale here, but that's basically like the size of a football field, and those are all beds, sort of foot to foot to head to foot. And so in the early 90s in New York, at the sort of beginning of this homelessness crisis, New York City opened a bunch of armories to provide immediate temporary shelter for homeless people. And that was the first response to homelessness in New York. This shelter, which is located in Upper Manhattan, actually not far from where I work now, was a particularly large and somewhat notorious shelter, and there were upwards of 1,000 men sleeping in this shelter every night. So so this is back then. Just to fast forward a bit, New York City still operates a very large public shelter system. It looks nothing like this. There are no shelters that look like this in New York anymore. It's a much more well-developed and sort of specialized system now, with special shelters for different populations. None of them, they're all operated by voluntary agencies, nonprofits. The city doesn't operate any shelters directly anymore. So the system is completely different now, much more well-organized, much more safe, and not a great place to be if you're homeless, but nothing like what was there. So that's just sort of a caveat. So anyway, so the work that I'm describing began here. So this was a place where people would just come in. There were all kinds of people there with all kinds of problems and needs all mixed up together. So almost all of them disconnected from any kind of health or mental health or social service system other than coming there for temporary shelter. Over time, this story is took years to sort of develop, and it's going to be telescoped in the way I tell the story, but over time, various treatment services and programs started to be put into the shelter. So there were what we would now consider, I think today, like outreach services actually in the shelter to try to identify who was there, what kinds of needs they had, try to engage them in some kind of help, treatment, services, support. There was an on-site medical clinic went in there, on-site psychiatric clinic went in there, other services. As you wouldn't be surprised to learn, over time it became clear that there were a lot of people in there with severe psychiatric problems, substance abuse problems, untreated chronic medical needs. And over time, the teams that were operating there got pretty good at engaging people in care, helping to provide treatment, getting people stabilized, and much better off. Over time, again, in New York City, there slowly began to develop various housing alternatives. So at that time, pretty much the emergency shelter system is what was available. City and the state started building housing, sort of some early sort of models of what we would now call supported housing, group homes, community residences, other kinds of options started to develop. And the team was able to begin to place people into housing, and connect them with services in the community, give them discharge plans, and that was, sort of a success and was seen as a big success. What ended up happening was the team that was working there started to realize and started to see over time that a significant number of people, even after they had been sort of stabilized, connected to treatment, given discharge plans, placed into housing, some significant number became homeless again kind of quickly. Some of them came back to the shelter. Some of them went elsewhere in the shelter system or went back on the street. So CTI was really an intervention that grew out of this sort of experience of social workers and other people working in the shelter to try to help people be able to take root and more effectively retain housing and support that they were getting in the community after they left the shelter. And so this is what led to this focus on this transitional period. Transition from, in this case, the shelter into housing in the community. And it made the team think a little more about what was happening for these people and what could they do as part of their intervention approach that would help people be more successful in this transition. And so the team actually started to think about this period of transition as a critical time, and that's where the name comes from, critical time intervention. That a transition period from an institution to community, and certainly probably in your work you can think about other kinds of transition periods in people's lives that might share some common elements here. That transitions are difficult, and they're difficult for everybody, but they can be especially difficult for people who have a lot of problems, and disabilities and lack resources. And these were certainly people who had a lot of complicated needs around health, mental health, substance use. A transition can often involve a loss of support. In this case, people were going from this shelter that obviously was not a great place to be, but it was a place they had been for a long time. It was their home in a way. They had friends there. They had relationships with workers who worked there. They knew the neighborhood. And then they were going to live somewhere else. So there was built into this transition period, there was a loss of support in that transition. And they were going into a system, even though that they had discharge plans and set up for the new place they were going to live, for where they would go for mental health treatment, or where they would go for social services, and what their housing was going to look like. These systems, as you know, certainly in New York, and I suspect here, tend to be very fragmented systems. You know, it's not like a woven together support system. It's like a bunch of programs and services that don't typically work very well together. And so all those things contribute to sort of like, to sort of a difficult transition to not really being able to necessarily provide the kind of support that's needed during the transition. So this is what was the stimulus for this approach. So what CTI tries to do is just say, well, we're going to focus more on that period of transition and try to do something or some things during this transition period that will hopefully have a long-term positive impact on the person's outcome. So CTI is a time-limited intervention, but that spans the period of transition. I'm going to describe a 9-month model that we've used for CTI, but the purpose is not just to provide support and help during the 9 months. The purpose is to do things during the 9 months that will then have a lasting positive impact. So that's the simple-minded idea of CTI, and it's meant to be kind of a fairly simple-minded approach in the sense that it's a set of sort of principles and steps that we've used in this particular setting but perhaps can be applied, or some of the logic of it can be applied in other transitions with other populations and other kinds of settings. So, you know, maybe we'll be able to talk about that, or you'll have some ideas about that after you hear about it. So it's essentially a case management approach in some ways. There's a worker who is working on an individual basis with a client or consumer and trying to arrange and link to services and supports. I mean, depending on how you define the term case management, you know, that sort of sounds like some versions, some flavors of case management. It differs in a few different ways. For one, as I said, it's time limited. It's not ongoing. In this version of CTI, as I said, it lasts for 9 months. It's more sort of highly focused than some case management programs. So the idea here is to focus on only a small number, a handful of priority areas that for that particular individual place them at risk of becoming homeless again. So as I said, and you know, these are at least the people we worked with here who had, like many of them, a multiplicity of problems and needs and disadvantages and rough life histories. But the idea of CTI is not to sort of help with everything. The idea is to help with a handful of things that's going to help keep them in housing after they move out of the shelter. And the other way it differs from traditional case management is that there are 3 explicit phases of CTI. Like the 9 months is broken into 3 periods, and the tasks of the worker are somewhat different in each of the 3 phases. So in phase 1, we call transition. So in phase 1, the job of the worker is to try to implement a transition plan and at the same time as providing direct emotional support to the person. And one thing that we have found, and we found it in this study, we found it in that shelter, we found it in the last study we did, is that the work, this CTI work, is much more effective if the worker who's doing it has already established a relationship of some sort with the person before they're discharged from the place that they're leaving, in this case the shelter. Because the whole idea of having a relationship and trust between the worker and the client that is there from the start seems to really facilitate the work, rather than the person leaves, goes out into the community, and then a case manager goes looking for them to try to, like that seems to work not as well. Here are some of the activities that the worker would do during phase 1. So this is the most intensive phase. I should have said these phases sort of take place in decreasing degrees of intensity of contact and work between the worker and the client going out over time. So in the first phase, the worker is very closely involved with the client, making home visits to where they're going to live. makes a point of trying to introduce the client to service providers, who they're going to be involved with, where they go, maybe accompanying them to early appointments with treatment providers or other sources of support. The worker meets with, and we use the term here, caregiver. What I mean by that is basically treatment, people who are providing treatment, or people who are part of the client's informal support network. So it could be family members, it could be neighbors, it could be friends, it could be anyone in the housing where they're living. Sometimes sort of substituting for those people in certain roles. And very importantly, part of the job of the worker is to act as a negotiator to help kind of smooth potential conflicts and that can take place during this early phase between the client and either the place they're living, treatment providers, family members, members of that person's support network. Now, another thing that's really important during this first phase is ongoing and continued assessment of the person's needs. Because what we have found is that the idea of sort of doing a needs assessment, which we're all taught to do, you know, in social work school and in social agencies at the beginning, and then kind of following that out, typically often is not very helpful. Because it's very hard to know what people's needs are going to be once they get where they're going. And so like the idea of a discharge plan that's made before the person leaves and goes in the community that then is terribly helpful, I think is limited. So this ongoing assessment is an important part of what people do. In phase 2, we're trying to the worker would like step back a bit. And here what the worker is trying to do is to facilitate sort of the system and observe kind of how well things are working. So less direct intervention and a little bit more of stepping back, and hopefully some things are in place by then. So here it's more a monitoring role. Sometimes changes need to be made, so the worker would be involved in helping to make modifications. And also intervening in the case of crises, which frequently do occur. In the third phase, which we call transfer of care, and by the way, there's if people are taking notes or all this is available, you know, on our website, and I'm happy to give you the slides, and so don't, okay. In the third phase, we have a termination. So phase 3 is really what happens there is mostly, it's still ongoing monitoring, but then an explicit set of activities that sort of solidify, hopefully, the support system that's in place. So there's an explicit termination. The CDR worker doesn't just like fade out of the picture. They actually have a planful way for ending the relationship in a respectful and hopefully a positive way. And some of the things that are done in the third phase, though there are two really important things. One is to facilitate some kind of a meeting. You know, best obviously would be a sit-down face-to-face meeting, sometimes telephone meeting, where members of the support system or whoever's involved in providing ongoing support to the person meet, and there's kind of some agreement about who's doing what. And ideally, the consumer or the client is involved with that discussion. At the very least, if that's not feasible, a separate meeting takes place with the client where the same kind of discussion takes place, and also kind of a review of what's been accomplished, you know, from when things started to where the person is now. Now, you know, in the best of all worlds, such a review would, you know, revisit like a positive trajectory, and someone would have something sort of good to feel, be able to feel good about where they were 9 months ago and where they are today and what's been accomplished. Obviously, that's not always the case. I said that we focus on priority areas. So here, what the point I want to get across is, while people have many, many needs often, the CTI worker is asked early on to identify a maximum of 2 or 3 priority areas they're going to focus their work on. In our work, and in the work in the shelter, and some of the work I'm going to describe, these tended to be the areas that they picked from for most people, because we were focusing, again, on a population of chronically homeless adults with long-term mental illness, substance abuse problems. And so these are the kinds of issues which tended to place them at high risk of recurrent homelessness. In other kinds of CTI adaptations with other populations, in other settings, obviously priority areas would differ. If you're working with homeless families, or you're working with kids, young adults being discharged from residential treatment centers, or people coming out of jail, it may look somewhat different. That's kind of in a nutshell very quickly on the model, and hopefully it's clear enough that the rest of my talk will make sense. As I said, there's more detail about, we can talk about it later. There's plenty more sources that you can get more information about how we did this work and stuff. The other thing I should say is, what are the values that guide CTI? And I want, our values are essentially around collaborative decision-making between worker and client. The idea that to be effective in this kind of work, decisions about what needs are like, what steps should be taken, what kinds of services and interventions and places to live are optimal. That needs to be a joint decision between worker and client, and also involving other members of support. So sort of collaborative decision-making is key for us. We adopt kind of what I would call a recovery focus, meaning that people have emphasizing really strengths, and strengths leading towards the possibility of recovery defined at an individual level. There are obviously many ways you could carry out the work, and different kinds of agencies and different workers could do what I just described in many different ways. But we emphasize kind of those approaches in sort of guiding the work. So I'll tell you now about a couple of studies that were done earlier on around CTI, and then I'll talk in a little more detail about a randomized trial, experimental study that I led that ended within the last year or so, and present some data that is not yet published. Actually, the paper describing the outcome of this trial was just accepted for publication in Psychiatric Services. But these earlier studies you can read about if you want more detail. So the first study that was done was led by my colleague Ezra Susser, that was at the Fort Washington Armory. And it was basically an experimental study there in that setting that I described, doing kind of what I described. And it was a randomized trial, so people were randomly assigned when they were leaving the shelter to either get sort of normal, usual good discharge planning and whatever else was available in the community, or to get that plus 9 months of intervention by a CTI worker. The study was 9 months of intervention for the CTI group, but people were followed out over 18 months. Again, the reason the design was done this way is, as I said, CTI is really intended to be helpful over the long haul. I mean, so the way to think about is it effective is not so much do people do better while they're getting 9 months of CTI, it's do they do better after that's over with, because that's really the point of the intervention. So they followed 100, this was all men because it was only a men's shelter, out over 18 months. And basically what they found was that over the full 18 months, there was people who were in the CTI group were 3 times less likely to experience homelessness during the 18-month follow-up. But they also found that the effect persisted in the second 9 months of the follow-up period. So that was supported the idea of a time-limited intervention leading to longer positive outcomes over a longer duration. Another study was carried out a few years later in the VA system. So the VA system, I don't know if any of you work in the VA system, but they've really done quite a bit in terms of trying to respond to the problem of homelessness among veterans. And they have many large programs, and they've been really at the forefront, I'd say, of trying to adopt what we would call evidence-based models into their standard practice. And so they were very interested in CTI, and they did what we would call an effectiveness trial. In other words, this wasn't a study, not a small experimental study where people were randomly assigned. They tried to sort of put CTI into their existing system and then evaluate how well that seemed to, whether that had a positive impact. So here really what they did was they had a big case management program working with vets being discharged from psychiatric hospitals and trying to get them into housing. They monitored how that worked over the course of a couple of years. Then in about 6 or 8 different VA systems in the country, they trained the workers to do the same kind of case management, but to use a CTI model. And then they looked at outcomes after the training. So it's what we would call a quasi-experimental study. It's just sort of making a change and comparing before and after. And in this study, which had close to 500 people in the study, they also found increased number of days housed for these people, and they also found some lower symptoms scores around substance use and psychiatric problems. So that led to the study that I'll describe quickly here that I led, which was an NIH funded study, where we said, well, this model seems to worked with people with mental illness leaving the shelters. How might we be able to use it in a more, more typical treatment setting, in this case, psychiatric hospital. So this study was carried out in 2 large state hospitals in New York. And that's a picture of Bronx Psychiatric Center. And it was also carried out at Rockland Psychiatric Center. So basically, state hospitals were people who were homeless, who needed long-term psychiatric treatment, went and then were discharged from. So what we did was we enrolled people in the hospital. We were able to enroll men and women, because obviously men and women both being treated there. And we essentially followed the same design as I described in the shelter study. So we gave people who people who were assigned to the experimental condition got 9 months of CTI, and we followed everybody for 18 months. And the main outcome we were focused on in this study, as in the original study, was homelessness. So we were seeing if the 9-month intervention, CTI intervention, could reduce people's risk of becoming homeless out over 18 months. I'll just go real quickly here so you get an idea of the kind of people we were working with. This just shows you the breakdown of the demographic breakdown of the sample. So it was more men than women, as is the case in the hospital census. These were mostly people who were sort of in their 30s and 40s. Primarily people who are African American and Latino, as again mirrors the state hospital population in New York, as well as the homeless population in New York. Our selection criteria for the study were a history and a current diagnosis of a psychotic disorder. So these were people who all had either schizophrenia or a schizoaffective disorder, and that was that was the group we were selecting. But as you can see, these were also people who had a lot of substance use history, and over 50% actually had met diagnostic criteria for substance use dependence. So these were what we would call sort of dual diagnosed people, many of them. Most of them had many psychiatric hospitalizations. So you can see there over a third. So 2/3 basically had 5 or more times in the hospital. and they were people who had had a lot of homelessness. So very few had only had one homeless episode in their lives. Most of them had had, more than 2, 3, 4. Many of them had had more than 5 or 10 homeless episodes. And many of these people had had long homeless episodes. So, we basically recruited the group of people who we were trying to recruit for the study. There were essentially no significant differences between the experimental and the control group. So here are some of the outcomes, the main outcome of the study. I think you could see the colors. So orange bar are the people who were assigned to the experimental condition, and the white bar are the control or comparison group. And what this is showing is the percent of people who were homeless I should have said, so this follows out over 18 months. We assessed people every 6 weeks to get their housing status. That's why there are 13 sets of bars there. So we followed people over 18 months. So the white bar is showing you the rate, basically the proportion of people who were homeless in that follow-up interval going out over time. And what you can see here is that basically the experimental and control groups are really pretty similar in terms of their proportion of people who are homeless during the first 9, 12 months or so of the intervention follow-up period. But then if you look out over time, you can see that toward the end of the study, there's really a pretty big difference between the experimental and control groups in terms of the prevalence of homelessness during each of those periods. And so the odds ratio there, the 0.2, basically we had originally said, well, we'll look at the end of the study and see what it looks like. Then we sort of said, well, the last follow-up interval maybe not enough in terms of enough observations or statistical power. So we looked at the last follow-up interval. We also looked at the last 3. And basically that 0.2 odds ratio is saying that people who were in the experimental group were essentially 0.2 times as likely to become homeless, or say 20% as likely to be homeless during those follow-up intervals. So these results are consistent again with this idea that a time-limited intervention can have a positive long-term effect, or at least long-term as far out as 18 months. This is just another way of looking at the outcome, which is comparing the number of total homeless nights in the two groups. So one thing that I think I alluded to already is that the idea that there are critical times of transition and that a critical time intervention is something that you would do during a critical transition period, could have long-term positive outcomes, is one that appeals to a lot of people thinking about different populations and different kinds of transitions. So we've been working more recently with a bunch of other kind of groups and service providers and researchers who are interested in adapting the model into other kinds of transition settings and with other populations. So we've done work with people who are working with young adults who are being released from residential treatment facilities as they quote unquote age out of the system. We're working with some homeless family providers. There are a couple of there's several NIH funded studies looking at trying to help people with mental illness who are being discharged from correctional facilities, which, as you may know, is many people with mental illness end up in jails and prisons, and many of them, when they leave jail and prison, they're at high risk of homelessness and other adverse outcomes. So those are some areas we're working in. We've even done some work in the RAISE program, which is kind of at the other end of the spectrum. It's for people who are young people who are beginning to just very early on in developing mental illness or schizophrenia in this case, and trying to think of that also as a critical time and what you could do in a time-limited intervention there. we're working with a bunch of providers, or ways we're trying to figure out, and I was talking to Jeff about this last night, that really a challenge for us now is to try to help service providers who are interested in using this model learn about it and get support to doing it. And it's not such an easy thing to do. So we've got some established relationships with some organizations whose job it is to do training and implementation support nationally. One of them is the Center for Social Innovation, which is based in Boston, which does a web-based training and other kinds of support over distance to service providers in the homelessness area. And we've actually gotten some funding from also from NIMH to sort of create a web-based curriculum for training in CTI and helping providers to set up CTI programs in their sites, and that's kind of an exciting thing that we're doing now. This is just a screenshot from one of the from that web-based training model that's just currently being tested. And so I'd direct you just to our website for any further information about the model. There's summaries of some of the research. There's links to the publications. I think my email address is there too. So anyway, this is just in case this sort of strikes your interest and you're looking for more info, that's the place to go. So I think good. All right, so that's pretty much the end of my formal presentation. And before we close, I just need to thank my sponsors here. I thanked the people who invited me, which is wonderful. These are the people who funded our research, NIMH, PI, where I work, Columbia, and NARSAD. So thanks very much for your attention.
Thank you.